Ladies and gentlemen, thank you for standing by. Welcome to the Healthcare Coalition's Governance and Sustainability webinar. During the presentation, all participants will be in a listen-only mode. Afterwards, we'll conduct a question-and-answer session. At that time, if you have a question, please press the 1 followed by the 4 on your telephone. If you'd like to ask a question during the presentation, please use the chat feature located in the lower left corner of your screen. If you need to reach an operator at any time, please press *0. As a reminder, this conference is being recorded Thursday, September 4th, 2014. I would now like to turn the conference over to Melissa Harvey, Acting Deputy Director, Division of National Healthcare Preparedness Programs at ASPR. Please go ahead, ma'am.
Thank you so much, and good afternoon. Welcome to the Healthcare Coalition's Governance and Sustainability webinar, and thanks so much for your participation today. In speaking with many of our Hospital Preparedness Program awardees and coalitions this year, we've repeatedly heard that coalitions want to learn from each other, and that's especially with regard to their governance models, some unique ideas for financial sustainability, and coalitions' roles during responses. So as a result, ASPR, ASTHO, and NACCHO are thrilled to collaborate to bring this webinar to you today. And we all recognize that your communities are really different throughout the nation. And we also know that your coalitions are also in various stages of development. So in considering speakers for today's webinar, we looked for diversity with regard to governance models as well as geography. And I have to say that while we always thought that doing a webinar like this would be a great idea, we did have a practice session about 2 or 3 weeks ago, and after that I've been even more excited about it because the information the speakers presented truly was phenomenal. So regardless of whether you're part of a coalition that is brand new or one that has been in existence for over a decade, I really think that you're going to learn something from our speakers today. But that said, we also know that many of you who are not speaking have fantastic ideas and tremendous coalitions. So we want to also hear from you. And if you're willing, we'd love to facilitate an exchange between your coalition and others that have already reached out to us for ideas and assistance. So please know you can always contact us at hpp@hhs.gov, and we would love to hear from all of you. In addition to the information you're going to hear in a few minutes and see during today's webinar, many of our speakers have agreed to share their coalition's foundational documents, things like their charters and their bylaws with you. ASTHO and NACCHO are going to be hosting these on their websites, so please stay tuned in the coming weeks for more information about where to find these helpful documents that I think will probably help you translate some of the ideas you hear today into practice. On behalf of ASPR, I want to extend great thanks to all of our speakers who have been willing and eager to share all of this information with you, especially regarding their processes for building coalitions, and that includes the hurdles and the barriers that they faced in order to do so. We know that each of our speakers is tremendously busy, and we thank you for all of your time and energy and dedication to the HPP program. I'd also like to thank our colleagues at ASTHO and NACCHO, who got really creative and helped us dig deep to find these speakers and the great coalition models that are going to be shared with you in a few minutes. And they also organized all the logistics behind today's presentation, so we greatly appreciate their help. And finally, I'd like to extend a special thanks to Bobby Courtney from the MESH Coalition for moderating today's webinar. So since we have a ton to get through in the next 2 hours, I'm going to turn this over to Bobby so we can get started. Thanks so much.
Thank you, Melissa. Really appreciate being here today. Thanks for the opportunity to moderate this webinar. Before we get started, I just want to, on behalf of myself and the presenters and frankly everyone on the call, thank ASPR, ASTHO, and NACCHO for hosting this webinar, for sponsoring this webinar. I'm excited to be here. I think it's a great opportunity to share best practices around governance, around programming, sustainability, and to really provide information on how to build a successful healthcare coalition. So I'll get right to it. Again, my name is Bobby Courtney. I'm the Chief Operating Officer and General Counsel at the MESH Coalition in Indianapolis. We're a nonprofit public-private coalition. Our mission is to enable healthcare providers to respond effectively to emergency events and remain viable through recovery. We're also a founding member of the National Healthcare Coalition Resource Center. At this time, I want to take a couple seconds just to introduce our speakers in the order they'll be presenting. Feel free throughout to submit questions using the online portal. However, we'll hold off until answering questions until all presenters have finished. So with that, quickly, I want to introduce Honora Lean, who's the Executive Director of the Northwest Healthcare Response Network in Seattle and King County. Kevin McCauley, who's the Healthcare Preparedness Program Manager, the Bureau of EMS and Preparedness, the Utah Department of Health. Linda Scott, who's the Hospital Preparedness Section Manager for the Michigan Department of Community Health. Ray Apodaca, Team Lead, Healthcare Preparedness Program, Health Systems Branch at the Texas Department of State Health Services. Jay Taylor, who's the Acting Director of the Bureau of Public Health Preparedness, the Pennsylvania Department of Health. And finally, Mary Russell, who's the Emergency Services Department at Boca Raton Regional Hospital in Palm Beach County, Florida. So with that, I'll turn it over to Honora first. Honora, you ready?
Yeah. So thanks. I want to thank ASPR and NACCHO and ASTHO for inviting me to be a part of today's presentation. I'm very happy to share with everyone the story of the Northwest Healthcare Response Network, which is a coalition serving in the sort of central and part of the South Puget Sound area in Washington State. We're a coalition that has a history going back about 2005 and is really one that has emerged out of the work of two strong coalitions, the King County Healthcare Coalition in the Seattle area and the Pierce County Coalition for Healthcares and Emergencies, which is the county south of King County. In 2012, our coalitions actually merged to create the Northwest Healthcare Response Network in an effort to better expand, streamline, standardize, and kind of enhance our coalition to serve the medical providers and the health departments and emergency response partners in the Puget Sound area. Our vision is really about working with healthcare to create a resilient healthcare system, and we've always envisioned from the beginning of our work, going back to the early days in 2005, that our coalition had to be comprised not only of work with health departments and hospitals, but really that our focus had to be across the continuum of care, and that we needed to be engaging across all types of healthcare partners for us to really build and sustain a resilient healthcare system. To give you a little bit more understanding of our geography and who we serve, the population in King and Pierce counties is roughly 2.7 million people right now. We have 2 local health jurisdictions, 2 counties, about 57 cities, and 3 tribal nations. From a healthcare service standpoint, we have 33 hospitals, numerous community health clinics, numerous long-term care facilities, and certainly many folks also served in the home health environment. In terms of scale and what this represents in Washington State, the hospital and long-term care footprint just in these 2 counties is roughly 50% of the state's hospital and long-term care facility beds. Although we are a heavily metropolitan area within both of these counties, there is also a fair amount of rural geography, and included in our hospitals are 2 critical access hospitals. We have the only level 1 trauma center and regional burn center for adult and pediatrics in a 4-state region. So there's a very high concentration of specialized services as well as pediatric facilities, VA, military facilities that are served by our coalition. What I really want to share with you today is the transition that our organization has gone through to become a 501c3. As I said, our history goes back many years, and for both coalitions and then up until January 1st of 2014, the coalition was administered by Public Health Seattle King County, and after the merger in partnership with the Tacoma Pierce County Health Department. And we, like many of your coalitions around the country, had staff within the Public Health Department that served to coordinate and to administer the coalition programs. In 2011, in early recognition that we wanted to start thinking about longer-term sustainability, we had the opportunity to partner with a local 501c3 foundation to work with us to help start a healthcare sponsorship program that enabled us to, back then, start receiving contributions from healthcare organizations to give us a foundation that would help us think about building our coalition and financially supporting our coalition beyond just using federal dollars. And that was an important step for us, and I'll touch on this a little bit later, because it gave us an important base for us to work from when we decided to ultimately transition to our own nonprofit. The transition for us was a 2-year process, and we have operated now independently as a 501c3 in partnership with both health departments, but as an independent organization since January 1st of this year. The transition really made some significant differences for us. Our coalition history was one with a very strong executive engagement group. We had an executive council comprised of executive leaders from the health systems and the 2 health departments. And in the transition to a nonprofit, we have transitioned that group now to a formal governing board of directors. Our history for many years, like many of you, was great coalition work done with no fees and just leveraging the federal dollars that were available to our region. As a part of the transition to a nonprofit, we have implemented a membership due structure, and this is a work in progress. We still engage with all healthcare organizations, but we recognized the importance in transitioning to a nonprofit that we would have to look at additional ways to generate revenue and offset other financial cuts we were receiving on the grant side. So we've implemented a pretty expansive membership program that engages opportunities for healthcare organizations, and very recently is now expanding to other community and business partners to be more formally a part of our coalition structure. In our early days, as I said, we received historically almost 100% federal funding for our work. A few years ago, we started receiving some contributions from healthcare to help us expand our work and build a foundation that was important for us when we decided to make the transition to a nonprofit. Now, as a nonprofit organization, we still do receive a significant proportion of our dollars from the HPP funding. We contract directly with the Washington State Department of Health as a recipient of those funds on behalf of our coalition. We also have membership dues. We are structured to be able to receive charitable contributions. As a charity in Washington State, we do fee-for-service work, and we do generate some revenue from events that we host, and this will be a growing part of our financial base as we expand the coalition and look for additional ways to diversify our resources. One of the benefits to the transition for the nonprofit for us as well was that for many years we operated with staff in 3 different organizations, sometimes 4 different organizations. The opportunity we created in becoming a consolidated independent organization was now the network actually employs all of our staff directly. The process for us to make the decision to jump to a 501c3, I just want to reinforce, was really a long process. It was at least 2 years in coming. But as we made the decision that we wanted to think more concretely about how to do this, strategic planning was really essential for us. And I want to reinforce, I think it's one of the most important things a coalition can do, is to really think very hard about who you are now, who you want to become, and what kind of expertise and resources is going to be needed in order for you to do that. As a part of our strategic process, we did do a formal SWOT analysis looking at the strengths, weaknesses, opportunities, and threats of our organization at the time. We recognized that some of the things that really were advantageous for us in considering the move to a nonprofit was, one, we had a very strong history of senior executive engagement from COOs, senior vice presidents, directors, CEOs of local healthcare organizations, and their commitment and work with us for so many years really enabled us to have effective collaboration and engagement with them to help with the decision-making to transition to a nonprofit. We had strong relationships with the health departments and other emergency response partners, and we felt the scope and body of our work was sufficient to translate into effective work even in a nonprofit structure. We had to think hard about the limitations in terms of what staff expertise we had, and would that be sufficient to transition to a business? What other expertise would we need to bring in? And we really had to think very hard and do some rigorous analysis about what the finances of operating as a 501c3 would be, and really do sort of pros and cons in terms of, did we think if we did this we'd be able to sustain in that new business environment and with all of those requirements in a way that would allow us to be successful as an independent organization. The transition for us, as I said, was about 24 months, and I want to just sort of highlight some of the steps that we had to go through. Upon the decision that we wanted to kind of look for something beyond just working within the health department, we did a comparison of 3 different potential business models. One, what would it look like if we stayed and maybe just restructured in the health department? Another was perhaps more formally aligning our coalition with another 501c3 in a more formal way than we were currently. And then the third was looking at a 501c3 option, which we decided if we went nonprofit would be the best structure for us. Once our Executive Council of Healthcare and Public Health Leaders approved the decision for us to look more formally at one of those structures, and we opted to look more formally at the 501c3 model, we then pursued a fairly robust business planning process, and that included an extensive strategic planning process where we really needed to revisit what was our mission, vision, what were our values, and what would they be as a new organization, and really understand what our strategic priorities and objectives would be in a new coalition structure as a nonprofit. We developed, with some expertise and advisors that we received on membership and financing, financial structure for membership, really had to look at the governance structure, and that meant bringing in the legal and business expertise to help us develop the appropriate legal documents, board structure, and other business documents we would need to have to operate functionally in Washington State as a nonprofit. We had to think about what our staffing model would look like in the new business structure and what the financial requirements would be with those, and really do some modeling and projections on what our revenue options would be in this structure. And I want to reinforce how important that was, and it's not something to underestimate. If you're thinking of undertaking the business side of a coalition, it is so important to really think about what your revenue beyond grant sources is going to be and how sustainable that will look for you. Once we had a final approval of our business plan, we implemented a founding member campaign, which was a request to healthcare organizations to make 3-year financial commitments to our organization, which would help us ensure that we had some stability in our financial base to get us started as an organization. And once we had that approval and that process started, we went head full on into implementing the nonprofit transition, which included doing all the business licensing, implementing an HR process, leasing new business space, and really focusing on the day-to-day operations of opening a new business. Just for example, let me go back one slide. I get a lot of questions about how do we staff our work, and I just want to share it was very important for us to think about all the different dimensions of our business operations. So I'm providing an example of our staffing model, where you can see we have a number of folks working on the programmatic side, but we recognized that how critical it was going to be for us as a business that we ensure the staffing of some of the other areas that would help us be successful, both on the philanthropic side, membership development side, and certainly the administration of the nonprofit business. All of our work is done with a great team, but we can't do our work without ongoing consultation and advisement from legal folks, both on the nonprofit tax side as well as employment attorneys, since we are an independent employer. We have information technology consultants that help us just run and function as a business. And then as a nonprofit, the bookkeeping, accounting, and auditing process is quite essential, so we've made sure to bring in the outside expertise that allows us to run all of those parts in an appropriate way, particularly since we receive both federal dollars and then also have other member and other revenue dollars we need to effectively manage. I always want to acknowledge and thank the contributions of our very important founding members who did make those 3-year financial contributions, and without their support we wouldn't have been able to make the transition to a nonprofit. In conclusion, and I know this is a lot of information, but I feel like as the executive director, I'm still learning on a day-to-day basis the unique dimensions to what it really means to run our coalition and sustain the great work that we've done in our community for so many years, but really think about how that applies in the business context. And all I can say is my learning is there are a lot of differences that you have to consider in what your coalition looks like once you become a business. You have to think differently about the scope of services that you offer and what you can effectively finance and resource in a sustainable way. And you need to really think about, as other organizations are starting to give you money, how you add value to those organizations and what their expectations are going to be for you. It's important to have a kind of ongoing dialogue with your community partners and to make sure that the appropriate coalition voices are a part of that decision making, but you also have to be ready, I think, to make the hard decisions about what's going to be most effective for your business which may not always be the same thing that community partners want to see. It's really essential if you're considering a transition to really look hard at different business and governance models and consider whether they are the right option for you. There are many great ways, I think, to do coalition work that don't necessarily require becoming a nonprofit, and really understanding the pros and cons of doing that and what's going to work most effectively for your community is essential. I can't underestimate or understate enough the importance of really, really looking at the financial model and the revenue, having a strong revenue development plan before you make the decision to transition. In our case in particular, because we employ so many folks, it's important for us to really know what are those dollars going to look like and to be able to think strategically about that. But I really encourage every coalition to do some very hard modeling about what the long-term finances will look like before you make the decision to go nonprofit if you're considering that. I also want to share how important it is to appreciate that unrestricted cash flow will be essential to being able to function as a nonprofit. We all, or many of us at least, benefit from the HPP dollars, and that's so critical to operating as a coalition as we have for many years. It's really important still to our budget. It's just slightly more than 50% of my budget. But it is very difficult to operate and almost impossible, I would say, to truly function as a totally independent nonprofit without some source of unrestricted cash flow to cover expenses that may not either be allowable by grant funds or that will be more readily and available in a timely way to pay for what you need before you can be reimbursed by the grant. Lastly, I'll just reinforce the importance of the legal and financial subject matter expertise at every step. It was essential to building our coalition at this point, and I rely on them on a regular basis in terms of ongoing management of the coalition. And I think it's really important for folks to think in advance of what the expectation of those that are going to contribute to your coalition financially will be. As they give money, there is additional expectation of what they get in return, and knowing that going into the development of your coalition is absolutely essential. And I really encourage those dialogues to happen in advance before they make a financial commitment or before you decide what direction you're going to go, so you can make sure you're aligning your business model with the appropriate expectations. And the work of the business of a coalition is always about demonstrating return on investment and continuing to demonstrate value. That means we have to listen very carefully, but we also have to be very strategic in the way that we organize and deliver our work. And I will wrap up my comments there.
Thank you, Honora. Again, as I said before, we'll hold off questions till the end, so we'll move right along to Kevin McCauley. Kevin, are you all set?
I am all set. Hopefully you're hearing me loud and clear.
Yep, we hear you.
Great. Well, thanks again to all the hosters and planners for this meeting. I'm going to present the model that Utah has chosen to follow for development of regional medical surge coalitions, and that is a local health department hosted model. A little bit about background for Utah. This is a bit of a busy map, but what you can see is that we have 29 counties in the state, about 3 million people. Actually, the 4 urban counties that are in the red outlined area, that's about 75% of Utah's population, and that's called the Wasatch Front. There are also 12 rural counties, and we actually have 13 frontier counties, which are less than 7 people per square mile. Also, in terms of putting all our eggs in one basket, for the hospital density in our northern 3 regions, and you'll see on the map that's northern, SST, and Utah Wasatch, about 87% of the beds in the state are in these regions and 86% of our population. Now, to show that we are in a, certainly have some vulnerabilities in this area, there's a yellow line going north to south. That is actually the major fault line for the Wasatch Front area, and it extends from Idaho all the way down to the center of the state. So not only do we have the bulk of the population, the majority of the hospital beds, but we also have one of the greatest infrastructure threats that exists right in our Wasatch Front area. What I wanted to do in this presentation is just do a bit of a comparison, because although we have 25 rural and frontier counties, we are actually the 6th most urbanized state in the nation. And with that in mind, let's take the first example of SST, which stands for Salt Lake, Summit, and Tooele Counties Regional Coalition. There are over 107 members on that, including each of the health departments in that region, 17 hospitals, 37 long-term care centers, and many others, including emergency management associations, outpatient, and other partners. And let's contrast that with our Southeast region, where they have about 12 members. That includes the 4 hospitals, a handful of FQHC, CHC clinics, a strong presence of the EMS agencies, and as a wise person who I heard on a prior conference tell me, it really follows the STP method, which is the same 10 people that are involved in most of the activities. So if we look at some of the key elements of the coalition, as I noted, our model for both of these is a local health department hosted model. However, for the SST, which includes 3 health districts, one, the Salt Lake County Health District, is serving as the host. In the other case, for Southeast, it is one host and 1 health district that covers 4 separate counties. Each of these groups are funded completely through HPP funds for staffing, training, equipment, and exercises. One of the big differences in the staffing is that for an area like the SST with its high number of members and lots of activity, it does require near to full FTE plus administrative support to manage the affairs of the coalition. Whereas in the Southeast area, it's more rural and frontier. Our rural and frontier ones use about a 0.5 to 0.6 FTE person who is employed by the health department. And just by way of numbers, for example, in addition to the funding for administrative costs, we provide a shared coalition equipment, training, and exercise fund. And so just for comparison, you can see that the SST, for example, gets about $45,000 to be able to do equipping, training, and exercise activities for its members, contrasted with Southeast, which gets about $12,000. For meetings, the SST is a bit more formalized, where every other month there is a full coalition meeting, and then on the off months there is an executive committee meeting. The Southeast, by comparison, they have a full coalition meeting that occurs quarterly, but monthly we actually have the coordinator do outreach and attend local emergency planning committees, EMS meetings, hospital emergency management meetings. And so as I'll describe a bit later, one of the key issues for us with just the amount of space in some of our more rural areas is it really takes a coordinator who is willing to go out to the facilities and work with them individually, because it can often be challenging just by way of mileage, but also by way of times of the year when travel from the remote parts of the state is not as easy as it normally is. In terms of some key documents, the SST, for one example, has bylaws and an MOU that's been signed by participating members, and they have a base response plan with very important sections including a resource management plan and a communications plan. By contrast, the Southeast, not quite as formalized, but still formal documentation, would be a charter that everyone agrees to the purpose and the functions of the coalition. They develop a base response plan, but the communication piece is as much a tree or a protocol as it is a detailed plan. And then something that's key for us that we've always encouraged our regions to do is that we recognize that there are some significant state-level threats that are identified through JRA or through the THIRA or a state hazards assessment. But we really want these regions to be most sensitive to preparing for those events that are most likely in their area. And so you can look at some of the priorities for our urban area, includes a pandemic, an earthquake, evacuation or falling down of a hospital, a large MCI, and certainly a utilities interruption that would impact the healthcare system's ability to provide care. And contrast that with our rural and frontier primary threats, include things like an MCI bus crash, certainly receiving earthquake evacuees that may come out of the Wasatch Front during an event and present into these healthcare systems, pandemic novel event, and there are many concerns about gas and oil extraction events that may take place in those areas, and then certainly severe weather and fire can not only cause infrastructure impacts, but most importantly can cause damage to, or can cause impassable roads, because in many of our rural areas there's really only one way to get in or out of these communities. So in terms of some of the factors we considered when pursuing the local health department hosted model, we first looked at historic factors, and that includes within the Salt Lake Valley, many of our Salt Lake City area hospitals participated in CSEP, which is the Chemical Stockpile Preparedness Program, where we had a munitions disposal facility that was within plume range of Salt Lake Valley. So there was an opportunity for hospitals to begin to work together many, many years ago. We also had the 2002 Winter Games that took place in Salt Lake. This became another opportunity for the Salt Lake area hospitals to work together. And then finally, the City's Readiness Initiative. The 3 counties that are in the SST region were also the 3 counties that were part of the CRI. We did an assessment of existing regions, including the historic Homeland Security regions, the HRSA bioterrorism regions from the prior iteration of the grant, and the existing boundaries of local health departments. We compared some of the existing regions against assessments of hospital catchment areas, which included normal patient access and transfer patterns with and between EMS and hospitals, and then looked at some significant geographic barriers that we experience in our state, including many mountain ranges and lack of roads into some areas. So local health departments and local health districts came as the host. We found that the local health districts actually approximately matched patient movement patterns as they stood. We also saw that local health departments were developing increased roles to fulfill ESF-8 functions in jurisdictions, and not just for traditional public health events. We actually saw that an opportunity presented itself for our local health department emergency response coordinators, which are our FEP-funded folks, to assist with not only public health functions, but to assist with medical facility and EMS functions in jurisdictional ESF-8 roles and in command centers. We also had a long history of success through the FEP program with working with our local health departments and ongoing excellent relations. That also, from our perspective, from the state perspective, it certainly eased the processing, budgeting, work plans, and other crossed I's and dotted or crossed T's and dotted I's for the activities of the grant. And one of the things that we were most concerned with is that, this really, a big piece of coalition is developing trust that the coalition itself and the coalition coordinator is there to support the local healthcare entities. And so our take was to use local people to serve local agencies and take advantage of those existing relationships. Now, we certainly can't go through all this and have everything work perfectly. We have run into some barriers or challenges that I'd like to briefly review. The first one is a communication gap that historically existed between some entities. For example, between local health departments, hospitals, long-term care. There was a lot of planning going on in silos. There was a little bit of overlap with some public health preparedness and response. But really, one of the ways that we started to get past that barrier is many of our regions will actually now rotate their meetings between coalition member sites, and then include a tour and a presentation by the meeting hosting entity so that they can get to understand the capabilities of the different entities that are a part of this group. We certainly have rural challenges, including up to 150 miles between some facilities. and also the fact that the response is county-based. So as I mentioned before, many of our rural coalition coordinators, we encourage them to travel to sites and do one-to-one meetings if you have challenges getting everyone to a full group meeting. And then also encourage the coordinators to attend any ESF8, LEPC, or any other relevant meeting that's going on within a county or within those communities, and just try and get about 5 minutes at that meeting to say, hey, we're the Healthcare Coalition, we're helping the jurisdiction to ensure that health and medical is supported, and that way others who have concerns can understand that we're there to support, not to take over or not to try and be incident command over healthcare. Related to that was some impression initially that the coalition was walking over some of these existing groups, like LEPC or existing ESF8 work groups. So we provided the directions to our folks to ensure that clarity is offered to all of the response partners in these communities that the coalition is an asset. We're building caches, we're building communication systems, and we're building plans to support impacted facilities. We can actually take some of the burden off jurisdictional emergency managers by having a coordinated system for health and medical. We did find that recruitment to these coalitions was often much easier than retention. So we ensure that the meeting content and goals are system-based. It's about the healthcare system, as all of you who work in this now realize, and that all participants can benefit from shared coalition funds. More recently, the introduction of the CMS proposed rule for emergency management has really been an opportunity for us to ensure that these coalition leads develop themselves as not only a technical assistance expert to entities that are just coming in, such as home health and hospice, but that they can help these entities fulfill some of the conditions of participation that are going to be required of any entity that bills Medicare or Medicaid when those goals are finalized. And then finally, we have seen some difficulty in completing some of the grant targets or resource elements, particularly the planning ones or the written ones, because often what we saw is there was a lot of deferral to the coalition to try and make progress on written plans. And in some cases, it even resulted in sitting through a meeting with a document up on the screen, trying to wordsmith, trying to get the language right, and it really put a crimp in the ability to just get these things out. So instead, what we've done is empowered the coordinators to go ahead and develop, borrow, steal, reappropriate existing content, get it out as drafts, and then seek edits. And that's been a big benefit to us in developing our written plan response planning targets. So in terms of short and long-term sustainability, you know, we may not be one of those states who is in a position to develop a model that is fee-based or to independently move into a 501c3. We are still dependent on the HPP funds. However, we believe that investing in this process and in the people that make it happen, that it's going to succeed. So currently about 40% of our Utah HPP grant goes to coalitions. We believe that sustainability also results from sustaining a regional cash training and exercise fund. This is an opportunity for all members to express what their needs are and to ensure that they're met in a way that is shared across the region and not held by any individual facility or held tight for some later time. It's meant to be spent based on the needs of the coalition. We work across all levels of responder agencies to define the value of the coalition, working with EMS agencies, fire agencies, traditional emergency management, to show that there is value in having a coordinated system of medical surge management and response. And then we take whatever opportunity we can to leverage the existing champions in our communities. And this is especially true in our rural areas. There is often one or two or three or four individuals that have really taken this emergency management under their wing and really feel that they are a critical piece. And we need to take advantage of that to make sure that this thing continues to go. In terms of longer-term sustainability, we do anticipate that we will still have a reliance on the HPP grants. However, as we develop program targets, one, for example, includes a yearly exercise in each region in which any member can play. So we know that the HPP grant only requires once every 5 years, but as we start to see these CMS rules come rolling out, there is required yearly exercises within that CMS rule. There are required yearly exercises within those entities that seek accreditation, whether it's Joint Commission, DNV, or any other accrediting agency. As I mentioned before, we see the region to be a primary point person on technical assistance to assist healthcare facilities with meeting the CMS-EM rules. We increased our interregional and interstate coordination. For example, we have a multi-region Vigilant Guard, National Guard exercise coming up in the fall, and we're going to ensure that we work between regions in the state to see how they can work together to support each other. And also, we have worked with some of our collar states. For example, our northern region recently had a meeting with the Southeast Idaho region to talk about shared activities and ways to support each other in an event. We do hope to see in the near future, and this may not be new to many states, but the development of regional resource hospitals. For example, our only burn center and our only pediatric specialty hospital are located in the Wasatch Front. And so if one or two of those is down or inaccessible, we may have to rely on hospitals that are not accustomed to receiving and holding burn or pediatric patients to have the resources and training to accommodate those patients until we can get the system back up. And then finally, we believe longer-term sustainability will be found through continued coordination with state and local EMS agencies for mass casualty planning. So in terms of materials and resources, I won't read the whole list, but we have quite a bit, including resource element assessments, checklists, shared regional equipment budgets, and you can see the list there. You are welcome to either contact me individually or through the hosting group for this call, and we'll make sure you guys get what you need. So that is all for me. Thanks to everyone, and I'll pass the ball on to the next.
Great. Thanks so much, Kevin. This is great information. We'll move on next to Linda Scott from the Michigan Department of Community Health. Linda, are you all set?
I am. Thank
Great.
you for the opportunity to present on behalf of the Michigan Department of Community Health, Office of Public Health Preparedness, and our 8 regional healthcare coalitions. And I have to say, including our leadership teams and the partners that really do the heavy lifting that make our programs so successful. As with the other presenters, this slide shows the geographic boundaries and the number of healthcare organizations and partners, which have remained pretty stable since they were formed in 2002. And really, we have a pretty solid core of partner composition within our coalitions. Each coalition has additional members based on their regional resources. The early HRSA grant asked that states or awardees, and I quote, develop, implement, and intensify regional terrorism plans and protocols for hospitals, outpatient facilities, EMS systems, and poison control centers in collaborative statewide or regional models. So Michigan established our healthcare coalition structure to align with the established emergency management districts, thus maximizing a framework that had already been established for planning and response to emergencies. And in addition, our state regional trauma system is being established to utilize these same boundaries, which really strengthens the relationship of emergency preparedness planning and response to day-to-day operations. These 8 regional healthcare coalition partners serve Michigan's 10 million population. So I'm going to discuss the Med Control Authority in more detail shortly, but I want to just outline as well the infrastructure of our healthcare coalitions. Each healthcare coalition has established a contract for a part-time medical director who's an emergency department physician with excellent knowledge of our EMS and growing trauma system. Each coalition has a full-time regional coordinator, and over time, each region has added an assistant coordinator due to the human resources needed to complete the deliverables of the Federal Cooperative Agreement, and probably more importantly, provide the extensive logistical support required for healthcare coalition activities, including robust education, training, and exercise programs, and of course, their role in response. Each coalition maintains bylaws originally established in 2002 but recently updated to ensure that all coalitions have the same consistent components to the bylaws, which really contribute to that consistent statewide planning effort. Identified in the bylaws are 2 required meeting structures, and these structures have been in place since the beginning of our coalition formation. The first is the Regional Planning Board, which is responsible for voting on the prioritization of program initiatives and the allocation of funding linked to those priorities. This board has voting members based on organization type and discipline representation, but is not linked to the size of the organization, so it's 1-for-1. Decisions are through consensus and developed by the coalition based on identified gaps, after-action reports, and each budget period priority initiatives established collaboratively with our office, which is the awardee. Each coalition also has an advisory committee, which is comprised of subcommittee and/or work groups. Again, these are established from within the coalition. So what does the coalition need to accomplish their tasks? And then our 8 coalition leadership team actually meets monthly as a group with our state staff so that we not only have the planning that goes on within the coalition, but the planning that goes on across coalitions and some of those statewide coordinated activities. So this webinar is focusing on the governance model, so it's important to understand the structure we have in Michigan, which really has enabled strong healthcare coalitions, not only during planning, but during response. So when we established our regional structure in 2002, it became clear that we wanted to develop a framework that would not appear to place any one healthcare organization as the primary subawardee for receipt of the federal funds and assume the responsibility to coordinate activities for all healthcare organizations that fell within that jurisdictional boundary. So after careful review, we decided to use something that is probably somewhat unique to Michigan, which we call a quasi-governmental structure called a Medical Control Authority, which actually is designated under Part 209 of the Michigan Public Health Code. So a Med Control Authority is administered by the participating hospitals and is designated by the State Department of Licensing and Regulation to supervise and coordinate emergency medical services for a specific geographic region. In 2002, there were 65 Med Control Authorities in the state, so we convened a meeting of this group, and they just self-identified the one Med Control Authority within each of those emergency management districts, which are now our emergency preparedness regions and our trauma regions, to serve as the fiduciary for the HRSA, now ASPR Cooperative Agreement. This agency really has continued to be a proven mechanism to ensure that hospital and pre-hospital partners, as well as the diverse membership of long-term care, local public health, and emergency management, to name a few, are really well served by our coalition. So like many on this webinar, in the early days of establishing the regional healthcare structure, we worked to implement the tiered structure outlined in the Department of Health and Human Services publication, Medical Surge Capacity and Capabilities. We know all response is local, or Tier 1, but for the purpose of this discussion today talking about healthcare coalitions, I will focus on the oval structure which is on this slide, which indicates the Healthcare Coalition Medical Coordination Center. So in Michigan, this is our Tier 2 Multi-Agency Coordination System, or MAC in NIMS terminology, which coordinates activities above the field or hospital level through the prioritization of the incident demands for critical or competing resources, and, very important, and, serves as an important resource to both local and state emergency operations centers. You will note that the MDCH CHECC, which we call our check, stands for the Community Health Emergency Coordination Center, which is responsible for ESF 8 and works directly with local public health and our Healthcare Coalition Medical Coordinating Center during response. The MCC is established and available 24/7, 365 in Michigan and has both a fixed location within each healthcare coalition, but can also be virtual or relocated to support operations as needed. So our MCC has proven invaluable to streamline communication and information requests, as well as has demonstrated efficient use of available resources. Now, many of you may be thinking, under what authority does the MCC function? Because I know we all hear what is the authority of our healthcare coalitions. So there are actually several ways that this entity does have authority, since both the Healthcare Coalition and the Medical Coordinating Center are part of our Michigan Emergency Management Plan, which has been signed by the governor, giving them a clear role in incident response. In addition, EMS agencies are guided by protocols. These protocols must be at least as comprehensive as the state model protocol developed by our state EMS office in conjunction with their state level advisory committee. In 2009, the Regional Medical Coordinating Center was written into our state's mass casualty incident protocol. So essentially, all med control authorities and all EMS follow this protocol. Now, I understand that you can't read this slide, but essentially verifies that the Medical Coordinating Center acts as an extension of the Med Control Authority, again, which is defined in the Public Health Code. It highlights normal activities that would include maintaining communication with involved entities such as EMS incident command positions, hospitals, local EOCs, our CHEC, which is our Community Health Emergency Coordination Center, and other med control authorities. It also recognizes a role in casualty transport mechanisms, coordination and distribution of resources and other tasks for an effective regional medical response. And of course, importantly, it reinforces the immunity for liability for the Medical Coordinating Center and those personnel staffing and performing the functions unless the usual act or omission, which is the result of gross negligence or willful misconduct. So as we talk about authority, as we talk about staffing these MACs or this Tier 2 Medical Coordination Center, this has been very important in helping us to establish our 3 deep roles which would be needed to fill the Medical Coordinating Center during an incident. This slide is just really for the purposes of review after this presentation that talks a little bit, kind of highlights the key points that I just discussed through our state model protocol and our Medical Coordinating Center. So now we'll kind of flip. So that told you a little bit about our state, a little bit of our structure, what our authority is. And so we have pretty mature healthcare coalitions with staffed infrastructure. So during budget period 2 last grant year, we started the process to pursue becoming 501c3. So this really started consistent with the January 2012 Healthcare Preparedness Capabilities document distributed by ASPR, where in Capability 1, Healthcare System Preparedness, it tells you that it needs to focus on developing, refining, and importantly, sustaining healthcare coalition. It specifically states to develop strategies to empower and sustain the healthcare coalition as an entity. So as I stated during the previous budget period, each of our 8 healthcare coalitions began to lay the groundwork with their advisory committee and planning board of the need to become a 501c3. As Onora noted, this is a complex process which requires careful explanation and planning and assurances that the healthcare coalition system, as it is currently established, will still be able to support their partners. Our healthcare coalition leadership have communicated that fact, and doing so will provide the opportunity for our coalitions to seek additional funds that can maintain their infrastructure and continue to move emergency preparedness forward for healthcare organizations and the community they serve in light of diminishing federal emergency preparedness funds. So we see this as an important path to financial sustainability and stability of our 8 regional healthcare coalitions. So this is a diagram that really lays out kind of those major milestones to complete this initiative. So although we started almost a year ago, we thought we would be farther along in this process, but I think Onora gave us a great presentation that just talks about what they went through to establish it for one coalition. We're doing this for our 8 coalitions. But due to the hard work completed thus far, we feel confident that we will be able to accomplish this goal by the end of budget period 3, or pretty close to June of 2015. That's our goal. Now, if you're thinking that this cannot be accomplished for the many reasons we struggle with, our healthcare coalition is too rural, ours is too large, or it's under-resourced, I'm really happy and proud to be able to provide an update of where our 8 healthcare coalitions are in this process. So I know that these numbers don't mean anything to you, but these are how we signify our 8 regional healthcare coalitions. So as you can see, each healthcare coalition has taken a slightly different path, and some are working together to utilize the resources available, like Regions 2 North and 2 South, whose medical control authority is already a 501c3 corporation, and they are integrating each healthcare coalition as a limited liability corporation as part of their med control authority. That's really our Southeast Michigan highly populated area, shares an international border. You'll note that Region 6 is noted twice on this slide as their med control authority serves both Regions 6 and 7. So they are working in several directions to support this project. Now Region 8 is our Upper Peninsula region, very rural, but actually the first region to get their application paperwork submitted to the IRS and the state of Michigan. So you can see that, as Honora stated, you have to look at what's going to work for that region and then establish the structure that meets that region's need. So anybody liking more information can certainly get a hold of me and we can talk a little bit more in depth. So the most important message from Michigan today is that our regional healthcare coalitions continue to demonstrate value to their partners, not just medical and public health, but also emergency management, law enforcement, non-governmental organizations, and other participating entities. You may have heard that Michigan recently had significant flooding in Southeast Michigan, some of our highest populated areas with many healthcare organizations. 2 of our healthcare coalition medical coordinating centers supported their organizations continuously through this response with continuous communications and the identification of resources which might be needed to continue several hospital emergency department operations that had to temporarily modify their operations due to the impact of the flooding and space. Using this structure, this medical coordinating center, that Tier 2 MAC, 3 healthcare coalitions through their medical coordination center put a query out to their coalition members and within hours had identified requested equipment and supplies should they be needed. This really demonstrates continued value to coalition members, that it should be ongoing, and it's critical steps like this towards continued participation. Again, not just planning, but also for response. And I think that's really the take-home message, is that it doesn't have to be a catastrophic incident. When you have flooding in a highly populated area, that's pretty catastrophic to that community. So the Healthcare Coalition really serves a role in day-to-day operations. Finally, this slide lists some of the tools and or resources that Michigan has developed which may be of interest to those of you on this webinar. Please don't hesitate to contact me, and it sounds like we're going to be able to put this information up on a website so you will have access to it. But again, we'd be willing to share our coalition bylaws template. Each of our regions have operational guidelines which are all set up consistent with the CPG 101. So it's got a base plan with annexes and appendices. We've developed a statewide electronic patient tracking algorithm. We developed an essential elements of information template that we use and have utilized during exercises. You can get access to our ethical guidelines on the website that's listed on that slide. We have a pretty robust mass casualty incident burn surge plan, and we have a lot of resources for long-term care on our website. So with that, in that very quick overview, I'm going to turn it over to our next speaker, and I thank you.
Thank you so much, Linda. Great practical information, a lot of great resources for folks. I just want to remind our remaining speakers keeping to our times that we discussed, just so we can save a little bit of time at the end for questions. And with that, I'll go on to Ray Apodaca. You ready, Ray?
Yes, thank you for the opportunity to present and share our information today. And for the sake of time, I will attempt to quickly go through the overview of the process that we use in Texas for governance and sustainability of our healthcare coalitions. First of all, just wanted to share with everybody that our coalitions include 22 that cover the entire state of Texas. Us as the state awardee have entered into a contractual relationship with a lead agency for each of the healthcare coalitions that facilitate and administer all the day-to-day activities of the coalition in order to meet the grant requirements and to meet the state preparedness or healthcare preparedness expectations. Our 22 healthcare coalitions vary considerably in size by population and geographic area. They include small rural coalitions, mid-sized urban, and very large metropolitan coalitions. Our smallest coalition includes 2 acute care hospitals, and our 2 largest coalitions each have well over 100 hospitals, and all of our coalitions also include many other health and medical partners. Our coalitions have a minimum of 3 counties that make up their geographic boundary, and each has, as a minimum, at least a level 3 trauma hospital or greater. Also, our healthcare coalitions not only hospitals but include health and medical partners, EMS, public health, emergency management, and first responders. Present day, the way our coalitions look, because they have changed over the years since year 1 of the HPP program. But present day, we have 20 of our 22 coalitions that function as 501c3 nonprofit organizations, and that's based on the structure that our lead agency for the coalition has in place. So they function as part of their governance under a charter and or bylaws. Most of these, since they're nonprofit 501c3 organizations, already had a governance system in place before the HPP program. Because we used the existing EMS and trauma structure, most of these organizations already had that in place as part of the state EMS and trauma system. Most of those existing nonprofits, as I mentioned, use their existing governance structure, and in most cases just amended it and included HPP as a subgroup or a subcommittee of their existing structure for their regional healthcare coalition. 2 of our 22 healthcare coalitions present day are local health departments. And actually, I believe in this case, there was some challenges initially when they were selected as the lead agencies, partly because they're accustomed to being governmental organizations and not necessarily used to functioning under bylaws or charters. And also, they usually function under a political jurisdictional boundary where our healthcare coalitions involve multiple counties in a larger regional area. But they have been able to overcome some of those challenges since they were selected to be a lead agency. Our healthcare coalition since year 1 of the HPP program has been funded by us, the state awardee. We traditionally have pushed out 70 to 80% of our total grant award awarded to the state of Texas. We push that out to the local regional level through our healthcare coalitions, and we do that through the existing contractual sub-award agreement that we have with the lead agencies. Over the years, the funding formula and methodology has changed, partly due to the changes that we have experienced over the years with the HPP program. But we have always had open discussions with our healthcare coalitions to receive input and recommendations on how we should model our funding allocation formulas. Over the years, we have also conducted competitive RFPs to select the regional lead or host agency for each of our healthcare coalitions. The reason we chose the model that we have in place for Texas was partly due to the state legislature that limits the staffing that we can have as a state agency. And in order for us to be able to properly implement and administer a statewide program that includes well over 600 hospitals, we did not feel that we had the staff in place to properly administer and manage that. So we very much took the regional approach and elected to initially implement 22 regional contracts and have them be the conduit to all the health and medical partners in their region. We initially, in year one, attempted to partner with the State Hospital Association, like many other states have done, but in this case it did not work, and actually the Hospital Association declined the opportunity to do that for many reasons that I won't get into right now for the sake of time. But they have always, since day one to present, remained a very important partner in our statewide hospital preparedness program. When we elected to implement the statewide regional structure, we initially in year one did that with 22 nonprofit organizations. So we tapped into the existing EMS and trauma system that we already had contracts in place with those entities. But as I mentioned a little while ago, at about the 5-year mark, our agency decided that we needed to reevaluate what we were doing statewide and open it up to a competitive RFP process to allow anyone, including nonprofits, to compete for the lead role of our healthcare coalitions. And that is when our program started changing somewhat over the years, and we did end up getting some agencies that serve as the lead healthcare coalition agency that are not nonprofits, for example, the 2 health departments. Initially, in year one, we had 22 contractors to oversee the 22 healthcare coalitions, but over the years, because of the reduction in funding and some of the changes that we made in the expectations we had in our RFP to reduce some of the administrative costs, we have been able to reduce the number of contractors to where we now presently have 14 contractors that oversee 22 healthcare coalitions. So some of our contractors administer and oversee more than 1 healthcare coalition, and there have been significant benefits to that. Some of the difficulties and challenges that we have experienced over the years, several years ago, particularly in year 10 through 12 of the HPP program, we started realizing that as we tried to move our program forward and make it more mature and establish the level of preparedness that we had hoped for each of our coalitions, it was difficult because of the difference in sizes, the difference in resources, the difference in funding that each of the coalitions receive, that we were really encountering some problems. And through the advice of some of the coalition members, what we did is we took a step back, and what we did is developed a very detailed 3-year strategic plan, and we broke down every one of the HPP capabilities, or back then they weren't called capabilities, and I can't remember the word right now off the top of my head. But what we did is we took each one of those and we established a minimal level of preparedness that we were shooting for to accomplish in a 3-year program. And that way, depending on the size, the number of resources, and the number of funding that they receive, they were able to do it in an incremental process depending on the capabilities of their healthcare coalition. And that seemed to work real well for us and move the program forward. The other thing that has been a struggle initially, there was a lot of pushback nationwide with the coalitions taking on a response role. Some state awardees have really embraced that, and some have not. In Texas, we very much embrace that, and we could not be successful as we have had real-life responses without the coalition members that we have. They play a very important role in our statewide response, and the contracts that we execute with the lead agency, with the healthcare coalitions, there is an expectation in the contract language that they will respond. And because there have been challenges, particularly from emergency management in the early years, and resistance saying that particularly nonprofits, that they did not have a authority to respond. And the way we've done that is through our contractual relationship and also we issue some written mission taskings through our State Medical Operations Center when we deploy them as a state resource, and we believe that that has worked well for giving them the response authority and in some cases additional funding for the response. As far as short-term or long-term sustainability challenges that we have been dealing with, it was actually our coalition members that came forward in about year 2010, and as we started seeing the funds being reduced from year to year, we quickly realized that we needed to take a step back and try to determine what was it that we wanted to have in place for when this federal funding went away, whenever that day comes. What did we want to have in place? And one of the things that our coalitions really brought forward was the idea of developing 8 emergency medical task force teams that are made up of multiple coalitions and cover the entire state of Texas. And that's what we did, and that's what we've been sustaining and building on since 2010. But each of those emergency medical task force teams include ambulance strike teams, mobile medical units or mobile hospitals, nurse strike teams, and ambulance buses that have really played an important role for mass casualty incidents and for hospital evacuations. The program has actually been a great success and has been a great best practice that we have shared with others nationally. And we usually, we have those resources in place at the local and regional level, and they very much function day to day as a local and regional resource, but we have the ability and expectation to also deploy them as a state resource on a state mission. The other challenge that we have, same as everyone else, is with the reduction of the funding. We are very much concerned on our ability to sustain the 22 healthcare coalitions that we have. We feel that if the funding gets reduced further than it has in the last year, particularly since we allocate 70 to 80% of our federal award to the healthcare coalitions, we really have some concerns about our ability to sustain each of the 22 healthcare coalitions, and we hope that we do not reach the point with the reduction in funding that will cause us to lower that number below 22 and have to consolidate and make our regions even larger than they already are. Our coalitions have largely been successful because of the full-time staff that our coalitions have that are able to manage the day-to-day activities that the coalitions need to have in place for them to be able to accomplish what we think the federal grant expects, but more importantly what we expect as far as healthcare preparedness for the state of Texas. And I won't read the list, you can see it on the slide, but these are some examples of some of the resources that we can share. But before I conclude my presentation, the one thing I wanted to share is that the reason our program has been successful in the state of Texas is very much due to the passion and commitment that our healthcare coalition lead agencies and our healthcare coalition members have. We meet every month together in a statewide meeting in Austin and have been doing that for many years. That is where we provide guidance, we share lessons learned, and we really try to identify some challenges and barriers that we're all dealing with and really feed off of each other to try to keep our program moving forward. So that concludes my presentation.
Thank you so much, Ray. That was great. We'll move right along. Jay Taylor from the Pennsylvania Department of Health. You ready, Jay? Jay? I think we may have a little bit of a glitch. Maybe what we'll do is we'll move on. Mary, are you ready? And then if Jay comes on, we'll have him close.
This is Mary, and yes, I'm ready.
Mary Russell from Boca Raton?
Actually, I'm a representative of a local acute care hospital, but I am serving as a representative also for our Healthcare Emergency Response Coalition, which is in Palm Beach County, Florida. And let me advance this here. kind of interesting. We're located in South Florida. Florida has 67 counties, 7 regions, and 15 healthcare coalitions. So what's kind of interesting about where we're located is population dense. We have 1.3 million residents, lots of tourists, big geographic area, and you can see the density. I kind of thought it was interesting with Utah, 7 people per square mile. We've got like 670 people per square mile, and definitely vulnerable populations. You can see our elderly population. Out of all the older adults in Florida, 1/3 of them live in South Florida. So we have to consider that with, all sorts of issues that occur. In terms of hazards, clearly weather-related concerns top our hazard vulnerability analysis, wildfires, infectious diseases, and man-made disasters. Infectious diseases is kind of interesting because being an international destination, we're only a plane flight or a boat ride away from any kind of potential transmission of diseases. So we've endured things like weaponized anthrax attacks, obviously influenza, but more recently things like dengue, chikungunya, are on our list of things that we have to be concerned about, and certainly Ebola as well. And in terms of a governance model, we have kind of a different one than the rest of the speakers. We have our Healthcare Emergency Response Coalition is a program of Palm Beach County Medical Society services. Our Palm Beach Medical Society is a 501c6, but has a nonprofit 501c3, under which it has our Healthcare Emergency Response Coalition, Medical Reserve Corps, Project Access, and some others. And our mission is definitely aligned with theirs in terms of promoting quality health care. Oops, I kind of went too quick there. They were established in 2001. We formalized our coalition in 2003, so we are probably one of the older coalition models. We have a representative on their board, and they are a member of our coalition as well. Definitely aligned with our mission. They offered initially a centralized geographical meeting location because being such a large geographic area, that was certainly helpful. They got a consultant to help us get started. They provide a shared administrative coordinator, so it's someone who is in charge of disaster services with the Palm Beach Medical Society, but helps MRC, helps our coalition, helps other disaster-related functions. They provide the accounting and audit support for us, so that doesn't become a burden to us and a financial type of issue where that really definitely is helpful to us. And they provide a link to physicians, and I think that's important. They have 1,400 physicians within their medical society, and that's in addition to all of our acute care medical staff offices. So during H1N1, it was certainly helpful to have that link when that was a threat that, you saw such a surge at the private provider level. 10% of healthcare coalitions nationally are linked with medical societies. It's just another option if you need the additional support and don't have the financial structure to support a 501c3 all by yourself. We did explore that, doing an independent 501c3, and really didn't see the value and actually felt we would lose the support of being linked with such a strong organization. In terms of factors to pursue our model, we have actually been enduring things for a long time. We had a Category 5 hurricane back in 1992 where patients were evacuated by the busloads to other counties, and the whole state actually mobilized. And I think that kind of really jump-started a lot of agreements within our state that led to coalitions. We had an anthrax attack in 2001, and that was a weaponized anthrax attack with the first fatality occurring. So that was our first kind of venue into real bioterrorism needs in terms of preparation. We have strong working relationships with our health department and emergency management. They're at every meeting. They certainly advise us with threats and give us credible information, which is really, really important. Let's see, and we've been recognized as a special focus in terms of critical infrastructure, and I think that is, a strength. In terms of that, this was our initial venue. This was back actually in 2001 that, definitely woke us all up, and also was the mobilization factor for emergency response agencies to say, hey, we're in this all together. White powder incidents numbered in the thousands, and there was a need for equipment, training to manage any kind of contaminated incidents and casualties, and a need for coordinated public messaging for rumor control and education. So we saw the value of working together way back and organized back then. We have 27 voting members. These are our member organizations, includes all of our acute care hospitals. We have 14 acute care hospitals, and they are part of systems, corporate, not-for-profit, for-profit. We even have a VA thrown in there. They come to the meetings as well. Specialty hospitals, over 190 long-term care facilities with a representative representing long-term care on our steering committee, and also voting members. You can see Florida Health is our Department of Health, and you can see all the other agencies that you all have serving on your coalitions as well. And then we have trusted partners. Now, these are not voting members, but certainly invited members, because they provide value with all the other emergency response entities that we need. You'll see universities on there, veterinary care. We also invite students from the university's MD, MPH, like University of Miami students. They have at least 6 students come to every single one of our meetings on a rotating basis to understand public health support for coalitions, behavioral health, and it goes on, as you can see. Our kind of philosophy is that everybody needs to play together in the sandbox, and I think that's an important piece of this in terms of that everybody needs to kind of work together when there is a threat. And we saw this especially during the Haiti earthquake in 2010, kind of an interesting type of issue. Our coalitions in Florida worked together to basically coordinate the transport and transfer of over 700 trauma patients from Haiti. But we also recognized with the coalitions, too, that there was a tremendous workforce issue, that at least 15% of our workforce in South Florida was from Haiti. And there was a behavioral health concern that some of these people lost entire families over there. So that was kind of interesting on the responder side within the coalitions of how do we support that, how do we support each other. And there were a lot of lessons learned in mass fatality. I mean, we didn't want to do it like this, so that kind of jump-started a lot of our processes to say, hey, we could do a lot more. But that all went not only from the transport and treatment, but into recovery as well for these patients and repatriation. In terms of barriers or challenges, CEO support, definitely. We kind of managed that by actually hand-carrying our memorandum of agreement to every organization. Initially, this was just acute care hospitals, but we felt one common document kind of stressed how we're all in this together. And that kind of worked to get everybody on board. Our Healthcare Coalition membership definitely eases accreditation visits. Everybody values that, and we also share lessons learned at every meeting for those who are undergoing visits to say, what are they stressing, what do we need to worry about, how can we work together. We find that turnover can be a big issue for a strong hospital incident command system in that you kind of have rotating people, and you get people new to the area, new to our hazards. So, it's kind of not unusual to have C-suite people that have never even been through a hurricane, which for us is a concern, and we have to educate them. In terms of another barrier or challenge is membership turnover. We use the 3D incident command system concept to support attendance. We have designated and 2 alternate persons from each organization. These are designated by the CEO. One of them has to be an infection control practitioner just because of the concern of infectious diseases. Our Palm Beach County epidemiology comes to every meeting, and they brief us in terms of current threats. Attendance is tracked. Calls are made to non-attendees. We want to make sure that everybody does attend meetings, and if there's a concern of turnover, that we make sure that somebody else is assigned to roles. Another challenge is always communication. Number one thing to fail in disasters. We try to prevent that by having weekly radio roll calls, using communications equipment, and track that and report that. And that's important. You need everyday communication to make sure that you can respond in an event. And, antennas get struck by lightning, all sorts of different things that, we have to make sure everybody's equipment's always working. We have email distribution lists, mass notification drills to overcome that, conference calls during incidents. It's kind of interesting during major threats like Haiti earthquakes. We actually had to resort to phone conference calls, and everybody wanted that because of the support there to be able to talk to each other. So it's kind of interesting, even with technology support, that sometimes the lowest common denominator works in a disaster. In terms of sustainability, we poll our members. We find that the biggest reason people come to coalition meetings is they want the situational awareness. They want to know what's going on. They want to know about threats. They want to know about what's coming up with trainings or exercises and all these different things. For our first 10 years of our coalition, we charge nothing. And we actually only got HPP funding this year. So, we had no direct funding from the Hospital Preparedness Program for coalitions. We did start charging membership dues, I want to say at least 6 years ago. They were initially $250, now they're $500 for voting members. What's kind of interesting about that is for members that can't afford it, like our fire rescue, law enforcement, that kind of thing, our county commissioners have agreed to support the governmental emergency response member fees, and also they will pay membership fees for our newest members. Like we want to get more members from different agencies just to kind of fill gaps that we have. Oh no, I think just closed. Oh, that's interesting. Okay. We also have vendor presentations. You might have to advance my slides for me. All of a sudden it kind of got weird on mine. Nicole, can you advance my slides? Keep it to short and long-term sustainability. We do vendor presentations. We do exhibits at monthly meetings. We give the first 10 minutes of each meeting just to go over anything new that's out there that people might be interested in. And we have a list of sponsors that, examples that we can use for vendor funding. We do recognition events. We do breakfasts for our members. We do dinners for our members, recognizing their support. Also foundation support. We have a local foundation that gives a matching grant, Healthcare Foundation, and they've been wonderful to us in terms of giving us initial equipment and support for healthcare organizations, and they're also interested in expanding membership and helping us that way. And the last slide is the sponsors. You can see that there's definitely a range of them. You could advance to the next slide. We feel it's important to document and celebrate progress, so we definitely encourage any other coalitions to document your progress in an annual community report. We find that's really helpful for potential new partners, even for students that are attending the meetings, that this is what our coalition's all about. It's also good for local, state, and federal contacts who come to our area. Details coalition purpose, member organization, our activities and accomplishments during the year. Including training, exercises, equipment purchased by the coalition, and acknowledgement of sponsors. And if anybody has any questions, our coalition is happy to assist anybody across the U.S. We have all sorts of information that we can help you with. And maybe
wonderful. Thanks so much, Mary.
You're welcome.
And I've been told that Jay Taylor is back on the call. Jay from the Pennsylvania Department of Health, are you ready to go?
Yes, we're ready.
Okay, let's see make sure we can get you back to your slide deck. There we go.
Apologize for the inconvenience. One of those technical failures that occurred just as you were ready to turn it over to us, so we apologize for that. But thank you for having us. Anyways, Pennsylvania, we're kind of fortunate here with our healthcare coalition. The Commonwealth has established by legislation our boundaries, if you will, for our coalitions. And they're created in the form of task forces, which are conglomerates of counties across the Commonwealth, and we have 9 of them here in Pennsylvania. In each one of these task forces, the operating bodies have subcommittees, and each subcommittee aligns with the emergency support functions, ESF1, ESF2, and of course we have ESF8 in each one of these coalitions. So we're able to easily create the transition over for coalitions here for us. We still have some more hurdles to get through as far as funding goes, but some of the things that we have been able to do, I'm going to turn it over to Melissa Robbins. She's my manager here, who is our HPP coordinator for our healthcare coalitions across the Commonwealth. Melissa?
Thank you, Jay. As Jay was saying, here in Pennsylvania, we have 9 regional healthcare coalitions, and they actually were born out of legislation that created them back in 1998. They've been around, and they've been working through what they call regional task force model. They are comprised of healthcare facilities, EMS, public health agencies, long-term care, community groups, behavioral health. We've got emergency management agencies in there, and we have several other response partners like the Red Cross and some other community groups as well. They vary in size. Much like many of our other states that we've heard from, our coalitions are not really cookie cutter. Some coalitions are bigger than others. Some have more populations. Some are more rural. Some are more urban. They do vary quite a bit. In addition, they vary in the activities that they do and they perform. As far as governance, much like I just said before, here in Pennsylvania, we don't really have a cookie-cutter model, and I'm really glad to hear other states have seen the exact same things. You have to work with what's going to work best within your region, and that's what we've done here in Pennsylvania as well. As I said, our coalitions have been around since 1998. So they've got quite a history with working together. And yes, some of the partners and some of the members come and go because there's always turnover. However, their mission has really stayed the same. One of the great things that we have done is within our coalition, we've actually, we are working on a statewide MOU with all of our coalitions that will be that can be broken down by coalition if need be, but really what we were looking to do was to make it so that it could be cross-regional, so that we weren't just having it one little coalition in and of itself sharing stuff and then the boundary comes between another coalition and they can't share things. Well, we saw that as a real problem a while back and thought, you know what, let's move towards more of a statewide focus. In addition, we are looking at, and down the line, to extend that out to out-of-state, our border states as well, our facilities who are just right on the border who work every day with our facilities and our agencies within Pennsylvania to ensure that they're also included so that we can have a seamless response. Because as you know, disasters do not have borders. Some have adopted bylaws as well, some have not. They are working through that. Some have charters, some do not. Really, our coalitions here in Pennsylvania are kind of grassroots. I mean, they are volunteer. Not only do they not have to pay to be part of the coalition, but you know, they are volunteers, and they come because they truly believe that the work and the effort positively impacts a community with which they're in. So they really do go through the volunteer beginnings. Again, they do not have to pay fees. There are no membership dues to belong to our coalition. Some of the challenges that we are currently facing is that Pennsylvania right now, still we fund individual health care facilities. We are going still on our individual health care facility model. However, we are moving away from it. We are currently in the transition into a regional coalition funding model. And I was really encouraged to hear how some other states today have done that, and I'd be interested to getting some more information on how we can do that. We have several options that we are looking into, so we are currently transitioning into that. That's probably one of our biggest challenges currently right now, is our funding away from individual facilities going more towards regional coalition funding. Even though it will still be maintained as a volunteer model, it will still be more than likely will not require dues to belong to the coalition. We want to try to get them funding so that they can do exercises and do some big events within their regional coalition. What we do offer currently right now, as I just said, we don't offer our coalitions funding. They are still volunteers. However, we do offer them resources. One of the large resources that we offer them is we have our regional preparedness managers throughout the state. They are contracted through the Hospital Association of Pennsylvania here, And they work with our healthcare coalitions on preparedness, on exercises, on planning, and response. So that is one of the resources that we offer, the state offers our coalitions to assist them with their work and their planning and their preparedness. In addition, we have a web-based emergency management system that we provide to all of our coalitions, all of our individual healthcare facilities, our EMS partners, and our public health partners, and it's called Knowledge Center. And within that system, like I said, it's web-based. Within that system, we do all of our bed tracking. We can do our patient tracking. We do situational awareness, information sharing, and they can manage all their incidents and even their exercises free of charge. It is their system. They can log in, have their users from either their local healthcare facility all the way up to our state users, and they can use that to manage incidents and even manage exercises, and that is free. Free as well. We also have equipment and supplies available to them through a resource request process, and we have several other plans and response capabilities that we offer them, of course, free of charge. Again, these are just examples of some of the resources that we have. I mentioned our field staff for planning and response needs. We actually have 18 of them. They are broken into our regional coalitions. Some cover more than one, but we have 18. And Jay had mentioned that we really are focused on ESF 8. If you are familiar with the federal ESF, our focus is on ESF 8. So that is our healthcare, our public health, and EMS. And so we have our 18 managers out in our field who assist with these types of programs surrounding ESF 8. We also have 3 state medical assistance teams that are available statewide for deployment, either for a local facilities response or a coalition response or a statewide response. And our EMS strike teams, we have communication equipment, and again, I mentioned the caches. We also have pharmaceutical caches and PPE caches as well that we offer our coalition. For us right now for sustainability, that is what we are working on as we move out of individual healthcare facility funding and into regional coalition funding. So right now we are working on our sustainability plan, but we are transitioning. And that's about it for me. It's short and sweet. Any questions? There's my contact information. And again, I apologize for our delay. It was technical difficulties on my part, so I apologize for that. But that's it for us.
No worries. Thank you so much, Jay and Melissa. I really appreciate it. It's great information. I think we'll take we've got about 19 minutes left on the call, so hopefully enough time to get some questions. I'll sort of pitch to the Ready Talk representative to take any questions over the phone first.
Thank you. Ladies and gentlemen, if you'd like to register for a question, please press the 1 followed by the 4 on your telephone. You will hear a 3-tone prompt to acknowledge your request. If your question has been answered and you would like to withdraw your registration, please press the 1 followed by the 3. So once again, it's the 1-4 to queue up for a question on the audio side. And for now, I'll turn it back over to our presenters for the chat questions.
Great. So I'll just go through a couple questions, and if you have a voice question, just let me know. First and foremost, quick question, just a housekeeping question. Someone had asked online if the slides would be made available after the webinar. Yes, they will. I believe they'll be on the NACCHO YouTube page. Someone will have to correct me if I'm wrong on that, but I believe that's the case. And then if there are questions after the fact, you can email those to Nicole at NACCHO. Nicole Dunifon at NACCHO. Her email address is ndunifon at naccho.org. So just to get that out of the way. One of the questions that someone asked, and we hear this a lot, what are some of your revenue sources beyond federal and state grant opportunities? So I know that Nora spoke initially during her presentation about some development work and looking to identify potential donors, philanthropic donors, that sort of thing. What have other folks still on the call, other presenters, identified as far as additional revenue sources beyond the grant opportunities? I think I would just say whoever wants to chime in, go for it.
This is Mary Russell. The membership dues is one avenue. Vendor presentations or exhibits. We ask that they give us $500 to be able to present in front of the coalition members. Keep it short and sweet and make it generic. And they actually get a return on investment. They'll set up a booth, and it's amazing how many people are interested in the common types of subjects. Look for your local foundations. Make sure you have a presentation, and you give them a copy of your community report, who you are, what you'd like to do. Check with your county commissioners is one other issue and in-kind support is always valued.
Great points. Anyone else?
Yeah, hi, this is Michigan. Currently, our coalitions are 100% funded with HPP funds, but I think that your comment, Bobby, about the in-kind contribution of our healthcare organizations really can't be underplayed, because really there's a lot of work that gets done by our coalition healthcare organization members. But we are working really hard. That's why we're moving towards a 501c3. We've got lots of thoughts in our minds about what we will do once we establish that structure. Right now, our coalitions often help with a lot of community events, the International Auto Show, some of the marathons, and our coalitions are going to be looking towards those partners that they help now, but seeking some additional funding to offset some of those costs.
Great. Anyone else have any comments on that question on additional revenue strategies? One thing that I can say, at least from our perspective here in Indianapolis as a coalition, we've developed several fee-for-service programs, so leveraging our expertise in the healthcare emergency management space to provide emergency management services for some of our local hospitals under a managed services arrangement, working basically to provide expert consultation on CMS and Joint Commission requirements, which someone else I believe mentioned in their presentation. And one other comment I'll make too on your ability to receive funding. You're going to want to keep in mind the organizational model that you have. Some organizational models may limit the type of funding that you can receive. So, for example, if you're embedded in a public health department, that may limit your ability to accept foundation funds, so on and so forth. So, just to point out that some of these things may be organizationally dependent. Next question. Someone had asked whether or not there are other coalitions in Washington, and are they also nonprofit? I'll have to defer that question to Honora, and we can make sure she gets that offline. But I believe there are at least, I want to say there are 8 other coalitions in Washington. And I think at least 2 are administered by trauma councils, which are nonprofits. I'm not sure about the remaining, though. So we'll make sure that Honora Lean gets that to follow up on. Another question was, what percentage of each of the presenters' fundings come from 501c3, and is it more targeted towards equipment or other target areas? I think what that question is asking is sort of your revenue mix for your organization. So are you 100% HPP, which I think Linda had just noted, but moving to a little bit of a different model. What are the other organizations as far as your revenue, your mix of revenue?
Well, I can't speak toward the 501c3 angle, but for the local health department model that we use in Utah, it's about 75% of the funds support admin and about 25% support equipment training and exercises.
Kevin, are you still on from, or wait, was that Kevin?
That was me.
Yeah, sorry. Ray, are you on?
Yes, this is Ray from Texas, and it's kind of interesting listening to those that do use membership dues, because our coalitions are for the most part funded 100% with HPP funds, and we have had our coalitions ask about the use of membership dues, and we actually prohibit them because of the guidance that we got from our federal regs subject matter experts from our state agency. the way they interpret the federal regs, they indicate that if the members are required to pay dues or membership fees in order to be benefactors of the HPP federal funds, that would be considered an allowable reimbursable expense. So if Hospital X is required to pay a membership fee in order to be a benefactor of the federal HPP funds, they can request reimbursement for that fee, that membership fee. So it kind of defeats the purpose of the membership fee because they're going to get reimbursed. So because of that, and because of the guidance that our federal subject matter or federal reg subject matter experts have given us, we have prohibited those type of membership fees or that type of revenue. Because of our emergency medical task force response teams, since they do serve as a local and regional resource in addition to a federal resource, there are situations where they can be deployed. That's not through a governmental mission that could generate income, and we follow the federal regs with regard to that, and it has to be incorporated and brought back into the program as program income as spelled out in the federal regs.
Great, thanks, Ray. Can you speak to, while I've got you, can you speak to the mix of sort of administrative versus equipment when you look at your expenses for the coalitions in Texas?
Well, we do fund staffing for each of our coalition, and it varies depending on the size and number of coalition members on how much we allow for administrative costs. We have implemented some guidelines for trying to determine that. The last several years, we have pretty much tried to hold the line on that because of the reduction of funding. The big transition we made was years ago when ASPR started pushing the whole community health care approach and not preparing individual hospitals, but preparing the community or preparing the region. And that was a difficult transition that we implemented years ago. So now they more fund larger region-wide projects or projects that benefit multiple hospitals within their region. So we have seen some transition over the years on how those funds are allocated. We also, in my presentation, I mentioned that we carve out 70 to 80% of our total federal award to push out to our coalitions. In collaboration with our coalitions, sometimes we set aside dollars for statewide projects, like we have a statewide half-bed reporting system that we pay up front as the state agency on behalf of the coalitions because there's some cost savings for us doing it as a state awardee. And we do other statewide projects that we carve out money in cooperation with our coalitions because of cost-saving opportunities.
Great. Thank you so much. Anyone else want to speak to the revenue-generating strategies question before I move on? Okay, hearing none. The next question we have up is how common is the use of volunteers by coalitions, for example, Medical Reserve Corps, and how are they managed? Does anyone want to take that question?
Sure, I'll take a jump in first. This is Kevin from Utah. You know, the MRCs in our state, for example, are hosted by local health departments. And again, because we have a local health department hosted HPP model, what we've done is provided opportunities for MRCs to investigate medical response. Traditionally, they have conducted a lot of public health response, which is probably follows that they're hosted by health departments, but now they have an opportunity to pursue medical response as well. And through the coalition, we've been able to include them as members, get them engaged in training and exercises, and several of our hospitals have actually gone to the point of hosting MRC days at their facilities just to get the MRC teams into the building to understand some of the roles that they could do and to get them familiar with the facility. So it's really a developing success story from our perspective. That's all.
Great.
Yeah,
Thank you so much. Anyone else?
Yeah, hi, this is Linda from Michigan. We're very fortunate that our state MRC coordinator is also our state ESAR VIP coordinator. So we married the those two themes of volunteers for medical and public health together several years ago. So we have great MRC coordinators. Some of them, our MRCs, are managed at local public health. Some are affiliated with the coalition. Some are affiliated with faith-based organizations, but we coordinate the activities here in our Office of Public Health Preparedness, working through both programs. And we hope that we're supporting them the way that they need to be supported. And they are definitely important. We just did a big statewide exercise with our mobile medical field team, and they ran the show for volunteer management and did an excellent job.
Wonderful.
This is Mary from Florida. Medical Reserve Corps, the way we've used them, at least in our coalition, is they man call centers at our emergency operations centers under an ESF-8 mission. So, for example, during H1N1, they could answer questions from the community in terms of linking them up with information. They help us with immunization campaigns, again, another mission. Help us with neighborhood preparedness. Since we have so many elder-dense communities, it helps to make sure that neighborhoods are prepared, including points of distribution for, CRI and that kind of thing.
Great, thank you so much. There's a bunch of good questions in here, so I'm just going to try and go through a couple real quick in our last few minutes. For all of the presenters, have you found that any healthcare entities such as FQHCs, federally qualified health centers, are locked out of participating in the coalition because of dues requirements? For those coalitions that have member dues and whatnot, has that been a barrier to entry or participation?
This is Mary in Florida. Absolutely not. We would encourage their participation, whether they can pay or not.
Anyone else? I can say from our perspective, we are a subscriber-based organization. The hospitals in Indianapolis here have really made a commitment and really understand that supporting the broader healthcare infrastructure ultimately supports them. So, for those organizations that we work with who do not technically subscribe or pay dues to the organization, it's certainly not a barrier to us working with them. Another question, actually there's two questions here along the same lines. The attendee asks, we've heard a lot about HPP funding. How are FEP funds being used? Do any coalitions on the call receive any FEP funding to do the coalition work that they're doing? FEP being the Public Health Emergency Preparedness Program.
In Florida, our public health, our county health departments receive funding for, equipment and supplies and all that kind of thing. Our coalition does not.
Yeah, hi. In Michigan, FEP funds certainly contribute to our coalitions at the state level because they support much of the infrastructure that is used by all of our preparedness partners, not just the coalitions, but public health and many of the other disciplines. So, there are certainly shared resources that happen between FEP and HPP. And then at the coalition level, I think, again, it's more of that in-kind or shared exercises, leveraging resources to support coalition activities. All of our local public health are very involved in our coalition activities.
And Mr.
So it sounds
we
like
have a question on the phone as well.
that those FEP funds help foster collaboration across the various entities.
And
Absolutely.
this is
I
Ray
think
from
someone else,
Texas.
I accidentally cut someone off.
This is Ray from Texas, and very similar to Linda from Michigan. We look for opportunities to do cost sharing with HPP and FEP funds, particularly at the state level, whether it's funding systems that benefit both programs. But whenever we have an opportunity where we have particularly carry forward funds from the FEP side, we allow our healthcare coalitions to submit proposals just like anyone else from the public health side to submit proposals to try to fund specifically identified projects that are not recurring costs, but we're very thorough in making sure that the funds are being used to fund activities that are compatible with the capabilities of the funding source.
And we've seen the same here in Indiana as well, Ray. I think several states have taken that approach, which is great. Really quickly, we have 2 minutes left. If someone wants to chime in on this last question, any tips on facilitating the MOU process? We get bogged down in legal review between entities, and even though MOUs have limited legal expectations, that does create barriers. Any tips on the MOU process?
This is Mary in Florida. For some of the corporate systems, actually getting an MOU signed, enabled through one of the organizations usually opens the door for agreements to be signed through all of the system partners. So that's kind of interesting. Getting the VA agreement is almost impossible, but they basically have locally said they'd rather ask forgiveness than permission to support local disasters. So that's my take on that.
Great. Well, I want to thank everyone. We've got a minute left, so I'll close us up here. Thanks to our sponsors, ASPR, ASTHO, and NACCHO, for hosting the webinar. Thanks to our speakers, our presenters, and all of you attendees for calling in and listening. This has been great information. Clearly demonstrates along the lines of, in the context of governance, that it's not a one-size-fits-all model, as you've seen. Any remaining questions will be documented and distributed after feedback from the presenters. I know someone had asked on the chat whether or not specific contact information will be provided for presenters. I believe all of that is in the presentations themselves, which again will be hosted online and sent out again by NACCHO. And if there are any additional questions for the speakers, please email those to ndunifon@naccho.org. And then last but not least, I'll give a quick plug for the National Healthcare Coalition Preparedness Conference this year, which is December 10th through the 12th. And it's in Denver, Colorado. You can register at healthcarecoalitions.org. With that, I think we've hit 5 o'clock on the button. Unless anyone has anything they need to add, I think we'll thank you and say have a nice afternoon.